have you here with us.
Thank you.
Thank you. It's my privilege to introduce our next speaker, Dr. Kazem. She is one of the rheumatology fellows at Western University. Dr. Kazem completed her medicine residency in Vancouver. Her background prior to medicine is in healthcare and administration, as well as drug research. She's excited to start her practice by combining her previous experiences and by bringing innovation to healthcare and delivery. Dr. Kazem, welcome. I will turn the floor over to you, and thanks for being with us.
Thank you very much. I'm very excited to announce that I'm actually now graduated, and I am a new rheumatologist in Vancouver.
Congratulations.
So lots have changed.
We need to update your bio. I'm so sorry.
No, don't be. That's okay. This is quite recent. I literally wrote my exam yesterday. So
oh, wonderful.
I am very, very fresh. Okay. Can you see my slides?
I can, yes. We can.
Okay, and hopefully people will let me or let you and us know if there's any issues with the visuals. So I thought that perhaps today we can talk a little bit about management of digital ulcers. They're obviously a pretty huge morbidity for scleroderma patients, and it was a topic that was of interest to that is of a lot of interest to many of my patients. And when we discussed this, it was something that they thought that the organizing committee thought people might be interested in. So I have no disclosures in terms of conflicts of interest. What we're going to talk about today is really how do digital ulcers come about? How are they forming? Kind of what's going on? What's the impact on patients? And this is an area that really our patient population is much more knowledgeable. And I'm going to be talking about a little bit more of strategies that maybe we can really harvest that knowledge and put it into good use for improving outcomes and improving really the patient experience. We're going to discuss what's available currently in terms of management of digital ulcers, and just a brief discussion on emerging therapies and kind of the emerging themes on around digital ulcer management. So I give this talk to a lot of my primary care colleagues and my kind of younger colleagues, undergraduates or residents in medicine. So I always want to capture what is systemic sclerosis, or scleroderma. A lot of people are unaware of this, very surprisingly. And so I go through that. Obviously, up to 95% of people experience Raynaud's phenomenon. Now, this can be a triphasic, so 3 different phases of color change. Not all 3 phases are present in different people. It's very different for different individuals. And it's initially associated with a cold temperature response or a stress response, but it becomes a problem and it becomes pathologic when it becomes a self-sustaining response, as in the blood vessels really don't open up, they are not used to opening up when that stress or the cold environment or the exacerbating factor is gone. And that's when you get chronic lack of blood flow, and that's how the ulcers form. And of course, up to 50% of people with Raynaud's can develop, or sorry, with complicated Raynaud's can develop digital ulcers. So kind of a big chunk and big portion of the patients that we serve and our population. 15% will end up having complications with the ulcers. You'll probably speak or hear Dr. Janet Pope, who's my mentor, speak tomorrow. She talks about the 15% rule in scleroderma, that there is a lot of complications that have a similar type of trend. So 15% experiencing these complications. And these complications can range from recurrence of the ulcer getting infected, gangrene, to infection of the bone, auto amputation, or actually surgical amputation for infection control. So how are they actually forming? The current theories are that we have dysfunctional blood vessels at play. These are blood vessels that, as we discussed initially, all blood vessels can respond to cold by kind of constricting and really, spasming down to try and limit how much body heat we lose. These blood vessels, however, in a scleroderma patient with digital ulcers, they have lost the ability to really differentiate cold and warm and stress and non-stress and all the other factors that could bring on this contraction. And they are just randomly contracting and relaxing and contracting and relaxing. And when the balance of contraction and relaxation falls, goes towards the contraction, you have more time that the blood is not getting to the tip of the finger. Now, if this happens in the heart, you would be having a heart attack. If it were to happen in the brain, this would be something called a TIA, or a transient ischemic stroke, or actually the more severe form of it would be just a stroke. So really, this is a finger attack, an extremity attack, if you will. And once you have these episodes of blood not getting to the tissue gets upset. It gets damaged. It releases a lot of kind of help signals, inflammatory signals, that in response to those signals, you get more scar formation, if you will. And so it helps propagate and perpetuate the abnormal environment. And through repeat injury and scarring, you get narrowing of the vessels and obstruction of the vessels. And that's really kind of what we're trying to address, or that's how we understand it anyways. So again, just in form of a visual, you have the genetic predispositions, or an infection, or smoking, or all these other risk factors that we may or may not know about, that can really take a hit on, or make a hit on the blood vessels. And that, the initial hit, the blood vessel kind of takes a hit, tries to repair itself. But then when you have subsequent injuries of smoking, cold, trauma, this kind of exaggerated healing response, so when this becomes a self-sustaining pathway, these two together will combine and really end up damaging the blood vessel and making it thicker and thicker. In a response to lack of blood flow, the blood vessels try to grow larger. That's kind of where you get the nail bed changes, you get telangiectasias. But ultimately, the response and the damage overtakes, and this blood vessel becomes obstructed and obliterated, and any tissue around it would be affected, of course. So our goal of therapy, we don't have much control over genetics and predisposition. So we can't really stop this process from initiating in the first place. But what we want to stop is this repeat cycle of injury, further damage, and the maladaptive healing response. So kind of changing gears and going to impact of digital ulcers. And as I mentioned before, this is something that our patients are probably the experts on. So of course, they can have major morbidity associated with them. Looking at these pictures, and both of these are actually patients that I have seen. This is quite, goes without saying, to have your fingers go that color. It's extremely painful. It's really not conducive to any activity. And this can be kind of a one-time thing, or it can be recurrent, or you can have ulcers that become chronic. There's that persistent ulcer that just doesn't go away despite all the therapies. And of course, it goes without saying that doing any type of activities with hands that are so, in so much, you're in so much pain, you don't really have a good grip because of this and other factors associated with scleroderma. It can really interfere in the daily living. And again, the point of the slide is really when I present to my colleagues, to try and really um, of how debilitating this can be. Again, goes without saying that the quality of life is probably not the greatest if you're having ulcers of such magnitude, or even a small ulcer. It's, you're not getting blood, having finger angina. It's painful. It's quite terrible. And there's also some studies that what's going on in the fingers and what we can see on the surface might actually be what's going on in the internal organs. Now, the reason I have a question mark next to that is that, of course, we can't, it wouldn't be ethical to say, okay, you group of people get therapy, you don't get therapy, and let's see, in which group this is reflective of internal organ involvement. So we're just looking at, we're just kind of doing observational studies and looking kind of back in time, doing retrospective studies to look and see if there is any association between the number of digital ulcers, the severity of digital ulcers, and internal organ involvement, such as pulmonary hypertension or GI side effects. And because of this lack of standardizations that we have for all of our studies, we have conflicting results. There are a few studies that actually suggest that digital ulcers are a manifestation of vascular dysfunction in scleroderma, and therefore these people are more likely to develop pulmonary arterial hypertension, and have, so they need to be maybe screened a little bit more frequently. And then there are other studies that say that, well, in our population, when we looked, we didn't find such an association. And of course, the kind of economics of it all comes into play. A lot of places such as Australia and UK have published on utilization of healthcare. And not only, of course, again, it goes without saying that the quality of life argument by itself should be compelling enough to do something about this. But if somebody wanted an economic argument, it's there. There is a lot of healthcare resource utilization. And so really we should, one, identify this, learn more about this, and look a little bit more deeply into what we can do. More about the patient experience. When I was putting together this talk, I actually was surprised at how few qualitative studies. So we have a lot of studies on things that measure wounds and measure lung function and so on and so forth, but really that patient experience was very much lacking in the literature. There is again places like SPIN and of course the Scleroderma Foundation and a lot of support groups are fantastic in terms of really providing that forum for sharing of experience. But as an academic community, we unfortunately do not have that many studies, and we lack the insight, we lack full insight, I should say, and to the depth of the issue and how it really affects the quality of lives. And we say it's multidimensional, but really having studies on that would, I think, be quite valuable to the literature being comprehensive. So again, as I mentioned, many studies look at physician assessments of the issue. Part of the problem is actually that for a lot of these measurements for lungs, GI, skin score, we have these validated instruments, so these questionnaires that someone's developed or a group has developed. They've taken it and tested it in different populations of scleroderma patients and said that, no, this is a valid questionnaire, and the answers to this can really correlate with the outcome that we're looking for. Unfortunately, we don't really have a quality of, I mean, we have, there's the SF-36 questionnaire, that's kind of a global health, but we don't have anything specific to digital ulcers and how they impact the day-to-day activity. So lack of these validated instruments also makes it a little bit more difficult for research to be done exclusively in the area of digital ulcers. And the other overshadowing factors are severe organ involvement, that patients are often presented, or they present to their rheumatologist or primary care physician with fairly severe organ involvements. And if you are having pulmonary hypertension in the lungs, that's probably going to take precedence. Whether it should or not is a whole other discussion, but it would take precedence over the digital ulcer. Whereas, one can argue that prevention of the digital ulcer may also hold the answer to, well, prevention and treatment of pulmonary hypertension. So again, more on patient experience, of course, pain. It is probably one of the indications in rheumatology that we do write opioid analgesics for. It is, again, to try and compare it with something, it would be like the pain of a heart attack, except like it's at your extremities. You have a lot more nerves in the fingers as opposed to the surface of your heart. You touch and feel with your fingers. So the degree of pain is just unimaginable. And of course, if we are ever prescribing opioids, it's not all people can tolerate them because of the GI issues. It can cause motility issues. It'll slow down gut motility and intestinal motility. And again, you'll hear tomorrow more from Dr. Pope with regards to the GI issues, but the small intestine bacterial overgrowth is a major morbidity and issue that we have to deal with. So it's not always as easy as just writing an opioid and hoping that the pain would go away. Functional impairment, again, goes without saying that if your fingers are in that much pain, that much swelling, and you're having digital ulcers, there's not much you can do. The fine motor skills that would be gone, your daily routine, your work, and not to mention the emotional distress of it all. One of the papers that, one of these publications that had looked into patient experience actually had a focus group and people, and it coded people, and someone actually said that the pain that you felt in your fingers as they were dying was so excruciating that you almost begged to say, please cut it off. And a statement like this is so powerful and so impression forming that again, I chose to include it in my presentation to really impress to my colleagues and to our trainees when I give this presentation. So really, I'm being basically Captain Obvious to our audience that digital ulcers are not fun. So what do we currently have in terms of treatment? This is the big one. We do have a fair number of patients that are still smoking, despite having digital ulcers, very complicated digital ulcers. And really the beginning and the end of it all is that if there is smoking in play, we need to target that, because it doesn't matter what drug we give, how much we try and keep warm and prevent and so on and so forth. With further vascular injury, it's kind of a losing battle. We're trying to open up the vessels, you're tolerating all of these side effects from the different vasodilators, the drugs that open the vessels. You can get the headaches and the dizziness. But when smoking is on board and you have constant attack on the blood vessels, we're losing. In terms of therapies, so the drugs that we have, calcium channel blockers, generally we start with these with the first episodes of really Raynaud's, problematic Raynaud's that can be painful or bothersome. So we don't wait for digital ulcers to form before starting. If someone has Raynaud's, and of course, if they present with a digital ulcer, we add this on. There is nitrate compounds. I do believe there used to be a topical cream. Availability of it was a little bit of an issue over the last year. And so I actually would really advocate to work with your pharmacist to see what's available in terms of topical preparations. We also had oral nitrates, but again, they're quite poorly tolerated, and it's kind of one of our drugs that we go to if need be. There's these class of drugs, PDE5 inhibitors, sildenafil and tadalafil. They were, of course, again, serendipitously found to have vasodilatory effects. They were initially being developed as heart medications, actually. And we found that they are quite useful in opening up blood vessels for the fingers as well. And of course, when things get really bad, we take out the prostacyclin agonists, the iloprost, treprostinol, epoprostenol. Those are the ones that we need to get you in and kind of hang the IV. Because it opens up all blood vessels, people, again, have different reactions to them. It doesn't feel nice, but we're really, again, trying to open up those vessels and save the finger. And then more recently, these endothelin antagonists, bosentan, ambrisentan, macitentan. These were developed mostly for a management of pulmonary arterial hypertension, but we find that with if someone's having that degree of ischemia in their digits, they most likely have the pulmonary manifestations as well, and we find that they can help. And of course, we give statins and aspirin and kind of other vascular protecting and anti-clot forming medications, depending on what type of ulcer the patient experienced before, and whether or not there was any involvement of, or whether or not there was any gangrene, any amputation. So again, we really try and stay on top of it. Nifedipine, just a little bit of a history lesson. It goes back actually beyond, before 1980s. This was the world's smallest clinical trial with 9 patients that they found that at 12 weeks time, they had far less ulcers in the group that was being treated with nifedipine. And since then, there has been many, many more studies. So we know it works. Sildenafil, in terms of the rates of ulcer healing, we see that the group that got placebo versus the group that got sildenafil at 4 weeks, 8 weeks, and 12 weeks, these guys kind of healed faster. And at 8 weeks and 12 weeks, it becomes a statistically significant difference. So it's not just by chance that these bars are the way they are. And of course, iloprost is one of the medications that we give by IV. It opens up the blood vessels, And it actually may have some antiplatelet, so an antiplatelet activity, meaning that it can work like aspirin. And there is, so there's research to suggest that there is that aspirin-like effect. And literally fresh off the press, the group in Chicago with Professor Dinesh Khanna just published on the possibility that iloprost may actually try and restore those dysfunctional blood vessels. So it improves vascular function, and it tries to heal them in a way that's not maladaptive and that doesn't make more and more scar tissues. And it was they had everything from mice to human serum to look at all these pathways of how patients who had gotten iloprost may actually be doing this. What about combination therapy? So this was one of the themes of this year's International Congress in Scleroderma. That was held, I believe, in July. There's definitely evidence that combination therapy can lead to shorter time of healing for digital ulcers. Bosentan itself, I believe, was shown to prevent the rate of new ulcers forming, but by itself, it didn't statistically change time to heal. And again, the important thing to remember is that this is data from kind of a pooled group of patients. And my personal experience and seeing the patients with this disease, I find that there's such individual variability that we need to really kind of keep in mind that what doesn't work for someone may work for somebody else, and vice versa. And of course, there's other data that, they've looked back on patients that were on these combinations, suggesting that there might actually be a significant realized benefit. Other considerations, of course, we can't do this just ourselves. So we rely heavily on our wound management colleagues. That's wound care nursing. That would be plastic surgery, that would be orthopedic surgery. There are, wound moisture itself. There's a good number of publications on the importance of what is the optimal moisture level for the wound in terms of really making sure it's not, if it's too moist, it'll grow bacteria. If it's too dry, it'll just remain aggravated. So really deferring to colleagues who have more expertise in this would be something that, again, I try and advocate for. Wound edges, and again, this is like an entire science of how to approximate edges, and how to really make sure there's no necrotic tissue around it. There's infections. What type of, can we deal with it topically? Do we need to give systemic antibiotics? What about the dressing? There's, silver dressings, but they might be painful. There's dialkyl carbamyl dressings. Again, number of possibilities. These are, of course, for ulcers that are much larger and need more of an intervention. But nevertheless, all of these are really playing into that, and it's not a simple kind of take this drug and it'll be better type of a scenario. And there's some literature into surgical debridement and whether or not that's really the missing piece from optimal management of digital ulcers, and whether or not debriding that dead tissue and that necrotic tissue, would that be something that could really re-stimulate better functional growth around the tissue. So really this all goes to say that this is very much multidisciplinary, and it's not, just the rheumatologist or just the vascular specialist or the plastic surgeon or the wound care colleague that can make it happen. We all need to work together with, of course, the patient at the center and forefront of this. So what's happening in terms of new therapies? I'm unaware of any new class of agents. So right now, what's being looked at is to try and really classify ulcers that are the same into a make research a little bit more guided. A lot of people propose that ulcers that are, for instance, recurrent, they have a different pathology from ulcers that are chronic. So to combine these two groups of people and try and find kind of a one cure for all might not be very practical. So again, at the Scleroderma conference this summer, there was a few presentations on classification proposals and kind of how to go about looking at ulcers to try and again group the likes together and find out what's the individual and what's the specific treatment algorithm that best serves this group. This becomes a little tricky because this is a very, very rare disease, and of that, only half of the people develop ulcers, and of the half, only 15% develop complicated ulcers. So you could see how getting real-world experience in this might be a little bit difficult. There's, of course, the research into optimal dosing of current agents. There's a lot of research going on with iloprost. Should it be once, twice per month? Should it be kind of the 5-day regimen monthly? Should we do it for 6 months? Should we do it for a year? So those are the kind of things that are being looked at. And of course, for what we have, is there a new way of getting the compound to the fingertips? So our group in London did a very, very, very small study, just looking at tadalafil cream for treatment of Raynaud's and digital ulcers. And what we found, we had, again, very, very few patients. I believe this may have been like a very few patients, more than 10, I believe. But what we found, what we did was that for ulcers that were quite complicated and for people who were developing new ulcers, we gave them tadalafil cream that was provided to us by a pharmaceutical company. And we asked people to apply it kind of in between the web spaces of the fingers that they were having ulcers form. And at 4 weeks' time, we were able to actually see a difference in terms of our assessment of the ulcer. Again, these numbers are very small to try and make a case for it, but really this was a proof of concept that maybe tadalafil cream, adding it to the standard of care, so to the calcium channel blocker and sildenafil and, not sildenafil, it's the same class of molecule, but other therapies that the patients are on, it may have an added benefit for those really persistent, difficult to treat ulcers. So we're kind of hopeful that we'll get to do more with that. Really, at the end of it all, the management of digital ulcers is a huge area of unmet medical need in the scleroderma population. There is, there's some overlap, in fact, with the population of people who have peripheral arterial or peripheral vascular disease. And so, I would like to advocate for more research in this area in the hopes that we can extrapolate and, use this research to help those people as well, in addition to our patients who are having these terrible, terrible ulcers. Prevention is key. So really recognizing that first sign of, is this an ulcer forming? Don't wait. Go see your rheumatologist, call them up, let them know. Even during kind of the height of COVID, these were the patients that we were bringing into clinic for in-person assessment and possible therapy with the IV iloprost. Because if you get on top of it quickly, then we can hopefully try and prevent it from going further. And of course, recognition and adequate therapy can improve outcomes. Again, another Captain Obvious moment. And the fact that this is a multidisciplinary task. We can't do it alone, and we need allies in all disciplines. And with that, I'd like to conclude my talk, and I'll be happy to try and take any questions. Thank you.
Thank you so much, Dr. Kazem. Sorry, I'm just going to adjust my screen here as well. And we should just be you and I up here now. We do have a couple of questions, so I'll get those started if you don't mind. So Sheila asked, do you find the incidence of DUs are higher in and more severe in patients that smoke?
We definitely find the severity, yes, in terms of the number of digits lost. And sometimes we're kind of like, you know what, you're not going to have fingers to hold the cigarette anymore. And that's it's the conversation that I've had with a couple of my patients. And for, again, smoking and addiction is in itself a huge topic, and it's not just the physical dependence. So this is where we work with our pharmacists to try and use that multidisciplinary approach. In terms of more frequent, I don't have, like off the top of my head, I don't have data to support that. I do see it that if we have patients, in the clinic who have systemic sclerosis and are smokers, I think, again, referring to my memory, I do see a lot of them with digital ulcers. Yes, that's correct.
Thank you. Second question from Barbara. As an alternative to opioids, my pain management of choice has been polysporin with lidocaine. It's been very good control of the pain. So
that's excellent to know. And just kind of a comment, we do have, for patients who are experiencing severe pain and are intolerant of opioids, we sometimes again get them in and do lidocaine blocks of their fingers, and kind of, it's a terribly painful injection, but you just basically try and, numb the pain.
Okay, thank you. Next question from Luann. Thank you, Dr. Kazem. I have recurrent stress ulcers on my knuckles from tight skin. They take months to heal. Are you familiar with an ointment called chlorophyllin copper complex? Urea ointment. You see that there. Okay.
I think, yes, I do think that I've actually, I may have had this conversation with someone in the office. They mentioned it. I personally am not familiar with it, but I'm kind of very much in favor of whatever works, as long as you understand that this is, please don't forgo your nifedipine for this. But if you're taking the nifedipine and if you're taking your kind of skin thinning drug, and this works, that's great. That's fantastic. And I hope that, it would be something that I would hopefully try and suggest to my patients and see how they do with it.
Thank you. Is Tadalafil available by prescription now? So
it is, I believe. It is not, unfortunately, covered by any of the plans, but it is available by prescription, and you just need to go to a compound pharmacy to have it made. And I believe there's a couple in Ontario. I'm still trying to find kind of what's in BC, but one of my, again, personal projects is to find these resources nationally and connect with all of our providers and everybody kind of all over Canada and see where we can get this and where we can have this be available for access.
Thank you. I see, sorry, I'm just trying to get these in order. I alternate lidocaine, benzocaine for pain for an ointment and oral gum numbing ointment. So there's, Sylvia, have you suggested Botox injections in the fingers to any of your patients?
When we read the guidelines and kind of the literature and in our textbooks, Botox definitely comes up. Personally, I don't have any experience with it, and I don't have any patients who have tried that. But for kind of really, really persistent and difficult to treat, it's been a strategy that has been shown to work, but we don't have, again, huge data sets in terms of, making it a part of standard of care.
Okay, thank you. Susan writes, I appreciate your help with the topic of ulcers. I've had 2 and the last 2 just healed. Thanks to a new rheumatologist, got me no charge prescription at University, I'm sure, of Alberta Hospital. And it healed. And just being vigilant, so. That's,
yeah,
that's here, Susan. We're glad to, we know Susan here well at the office. She used to be a board member for Scleroderma Canada.
Oh, wonderful, wonderful. Wonderful. And yeah, so as you see, again, our patients are often kind of a huge source of knowledge to us. And, we wouldn't be here if it wasn't for them.
Of course. All right. Well, I think that answers all of our questions for today, unless there are any more coming in. And that keeps us just about on time. So perhaps we'll let you enjoy the rest of your day. Thank you so much for being with us. It was nice to see you. It's been a while since I saw you last. So I'm glad to see you're doing well. And we appreciate you and your time.
Thank you very much, and enjoy the rest of the conference, everybody.
Yeah, thank you so much, Dr.
Take care.
Okay, you too.
My pleasure.
Bye-bye.
My pleasure. Bye-bye.